Good morning. At the outset, I'd like to thank good friend Dr. Anjali, Steve, and all the HIV-NAT friends here for inviting me and putting me on the spot to do this talk on top 5 HIV development. I also have a disclosure. I've been keep doing this for the last 10 to 12 years in different international meetings. Started with top 20, top 10, now this time top 5. And what I have seen in the last decade or so in doing this talk is, whatever I used to talk, 10 years back, 5 years back as top 5 is become totally obsolete, today. So whatever I'm speaking now will completely change in 2 years down the line. There could be different top 5. That is because, as said by one of our earlier speakers this morning, Dr. Nick Patton, he showed a fancy car and a putt-putt. So in HIV, we received a lot of fundings in the past. I'm using the word in the past, so we are able to advance science. But that's not going to happen now because a lot of things happening in different parts of the world. So now the other way might be HIV now going towards putt-putt. So we may not know whether we'll be able to keep showing more and more new HIV developments. So again, in my talk, what I'm going to do is, there are a lot that happened in the last couple of years, 3 years or so, during the COVID and after COVID. It might be very difficult to give this talk in 30 minutes. So after discussing with some of the key stakeholders, I'm restricting my talk to top 5 only on the treatment perspective. I'm not talking about co-infections and STIs and in HIV prevention, just on HIV treatment. Before going to my hot talk, as we all know that, and WHO has released a guidance in the last IAS conference that U is equal to U. We all know this for last few years, 10 years or so. We are involved in this, doing this clinical trial, HP10052, and several studies and ecological cohorts. Everybody have said, U is equal to U, but officially it came, last year from WHO, where we released this guidance and stating that, with this evidence, definitely it is U is equal to U. I think this is something what we have to take to our clinics and speak to our patients, give a piece of encouragement, for sticking to their treatment. Now, going into my talk, I'm going to talk to you in the top 5, a study on the ART choice for the treatment failure. And I think I want to use this pointer. Okay, great, it's working. Thanks. This is great. And also we'll talk about a few words about dual therapy. You heard a lot on the Wednesday's afternoon symposium, but I'll quickly browse through this. I'll talk about some of the new studies been published last year and presented on the long-acting injecting strategies, and probably a regimen in the next guidelines for the pregnancy. And it's just an update. I'm not, don't listen to me on this, go and do a practice tomorrow in your clinic, but this is something, a strategy, might be make it up on ARVs and BNABs. And someone who is gaining weight because of the integrase, which we have been pushing and over-pushing, do you need to switch these ARVs? There are some new published evidence last year, which I want to walk you through. And of course, I will conclude my talk how we can prevent non-communicable diseases using science data, which we recently generated. First, going back into the WHO guidelines, we had first wonderful regimens, tenofovir, lamivudine, and dolutegravir, no doubt on that. And also now we have a good guidance on what could be the possible, second line public health programs. When you change from an RTI, you can change either to a PI containing therapy or to an integrase containing therapy. But we have been struggling and looking for evidence, what to do with the NRTIs. We used a lot, AZT in the past, and now tenofovir. And when you have been switching these TLE, tenofovir, lamivudine, and efavirenz, should we recycle the tenofovir or move them to AZT, which many of us have done studies and said that been highly toxic. But till today, the public health guidance is moving from tenofovir to AZT or AZT to tenofovir. Dr. Nick Patton, who is here, in fact, he invented this idea. I still remember for many years, we have been discussing this. He moved forward ahead of us, and he did this study, this beautiful study in Africa, and showed that yes, it's possible based on this sub-analysis, which I'm not going into that. It is not new. It has been already been published. When this study came, guideline makers and clinicians were keep pondering, can we go back and change our guidelines? But there is a small school of thought. We are not downsizing this study. It's an excellent study, well-designed study done by Nick and his colleagues in Africa. But it is more of Africa-specific. It didn't enroll in Asia, in other continents and everything. Just to compare this, I thought I picked up this study, which some of us in this room are investigators of this trial. Which this study was being developed by Kirby Institute in collaboration with many of us who are sitting in this audience, called DEP study. Again, to answer the critical question, what would be the best second-line regimen in a resource-limited setting when they are being failing in an RTA-containing therapy? It's quite a large trial where we enrolled more than 800 study participants. The regions include Asia, many countries, here in Thailand too, in India, Philippines and Malaysia, and a lot of African countries, and as well as Latin American countries. So it had a two-stage. Initially started with a two different arms, one with 2 NRTIs and boosted darunavir with 100 milligrams, which is a standard of care because the PA was being the standard of care as part of the WHO guidelines, which was compared against the boosted darunavir with ritonavir 800 along with the dolutegravir, which again a concept which earlier we have shown in second-line studies, and as well as other different studies supported by NIH, stating that this is probably a combination of integrase and a boosted PA can work. And when there is a demand came from the public health guidelines, can we recycle tenofovir to tenofovir? We added a third arm. So at that time, if anyone who is already on TLE, who has been failing, recycling the tenofovir along with the dolutegravir. There is a small addendum to this protocol, but didn't cause any huge damage to the design of the study. Now, this is the baseline characteristics. Now it has been presented. Now it's been submitted for publication. So where we have a very large proportion of the patients being recruited from Asia and Africa, and as well as from Latin America, in all these arms almost like with a similar in baseline characteristics. Just going to the snapshot analysis, if you look into these, both in the stage 1, where we had 2 arms, as well as in the stage 2, where our test regimen, which has been non-inferior to the standard of care. The standard of care is shown by these green bars, where it is a combination of 2 NRTIs and the boosted PI with darunavir. But again, the orange being dolutegravir with the booster darunavir, and again the blue being recycled tenofovir along with the dolutegravir, which has totally been non-inferior. In fact, this particular regimen of dolutegravir and darunavir has also been we also found been superior. Now, following this, we concluded this study stating that these 2 other test regimens, that is TLD, which is switching from TLE, and as well as this newer regimen of dolutegravir and boosted darunavir, is been non-inferior. And in fact, dolutegravir and darunavir ritonavir has been superior even to 2 NRTIs and with darunavir and ritonavir. And also, we found that these regimens have been well tolerated. There is no major serious adverse events to discontinue or any deaths. And these study participants will be followed up to week 96. And this data, hopefully, if accepted, will be presented at CROI as a late breaker. This is something what we are known. So what's the takeaway from this study to the next guideline is, definitely we have now solid evidence. Dr. Patton and co have shown in Africa. Now our DEP study, where many of you have been sitting here, we recruited patients here, have very clearly shows that we can definitely recycle this. And also we went one step ahead in this DEP study. We also have another regimen where you can't use tenofovir because they have toxicity or probably for some reasons. And if they are not co-infected with hepatitis B, you can definitely use this regimen of darunavir 800. Now it is getting widely available, even through generics, and along with along with the dolutegravir. This is something what we came up, which I felt probably should change your practice when you go back to your country soon. Now moving to these next one in the top 5 is on tenofovir-related toxicities. So this is the data from our own clinic. Many years back, we published about the cumulative toxicities to tenofovir to renal dysfunction. And also we have a data from our own region through the Treat Asia cohort study, which we published many years back, which was almost similar to show that tenofovir on a long run can be toxic to our patients, to the bones, and as well as to the kidneys, which is already being seen. And because of that, you need intensive creatinine monitorings and so on and so forth. Now, can we drop this tenofovir? Do you have other regimens available? So what about this dual therapy? Can we do this? I don't want to go into the details because we had a very good symposium, lunch symposium by Chuck Hicks, and he walked through all the studies, but I like to show just one or two studies, what was new last year, which can impact your practice. Which we all know that Gemini is a study, it's a week 48 data, which now we have got data up to 144. Following this data, which is a study which compared 3 drugs versus 2 drugs, that is tenofovir emtricitabine with dolutegravir versus dolutegravir and 3DC, even in a naive population, and as well as it's also been heavily studied now in people who have been well suppressed with ARVs and subsequently used as a maintenance therapy. It shows that definitely this 2-drug therapy has been non-inferior. Following these 4 years back, the US FDA approved this particular combination as a Dovato and it's become part of the guidelines in the developed world in North America as well as in the Europe. So and you may ask a question, hey, they did that, why we never implemented this in WHO guidelines or in our regions? These are 2-drug regimens. Don't forget that many of our patients, when they failed, they all had mutations to NNRTI, and significant proportion of them also had mutations to 3DC, because this is one of those M184V, which is a mutation to 3DC, which occurs very quickly. It's one of the first few mutations when we very long back studied about the viral dynamics in terms of treatment failure. If that's the case, especially in our region, if you're going to put these patients on these 2-drug regimens, there could be a potential danger of this DTG monotherapy. This was been pondering to our mind, how we can use this data and which is approved drug in our guidelines. To start this out, last year, this was a very nice presentation. I thought this could make a change in our guidelines. What they showed is the IAS presentations, and I think it's still not published. It's going to be published soon. So what they did is, they recruited 100 patients. These are the patients who had a suppressed viral load, but they can have a previous failure, with any regimens, but they can also have M184V mutations. So what they did is they recruited for this study, and it's a one-arm study where they use dolutegravir and lamivudine, and they stratified as 1:1 with the presence of history of M184V mutations from their first failure or from the baseline from the stored samples. And the study has been followed up to 144 weeks, with the primary endpoint of HIV RNA with more than 50 copies at week 48 and with the 96 with the intended treat analysis with the FDA snapshot design. I just want to go into this snapshot analysis, and very interestingly, they found that this M184V mutation present didn't make any difference. What they found in that is, even if they don't have M184V mutation, the chance of viral suppression is almost very much similar like the presence of M184 mutation when they have this 2-drug therapy. And very clearly shows that the virological suppression is similar. There is no virological failure and treatment emergent resistance through week 96. This completely solved our one clear question on the usage of this 2-drug regimen, particularly in the context of our treatment failure and as well as presences of M184 mutations in our patient population. So today, in my clinic, I use this drug a lot because it's been available in my country, even through generically. So we use this in our clinic, someone who has already been suppressed. So we have not started using in people who have been treatment naive. And once we start on this, we immediately do a viral load very frequently in the first few months, just say that, okay, they have been fine. Then after that, we follow the public health guidelines. And very importantly, this regimen is not recommended in hepatitis B co-infected people because in our region, anything from 4 to 9% of our patient population can have this. So you have to roll out this. And also, we do not have any good data in TB patients, especially doubling the dosage of dolutegravir. So this is something, again, need to be studied. But on the other hand, I personally feel that this might make to the guidelines by next year, and probably you may use it in our region. This is something what our patient need when they are virologically suppressed. Can we relieve one of the drugs which might be toxic on a long run, which can protect the kidneys and as well as the bone, thereby our patients not only just virologically suppressed, they are being not being comorbid. Moving to these, third one, in my top 5 is on about the long-acting injectable. So this is a story which you all know that for many years back, it's now been shown that these 2-drug long-acting injectable as cabotegravir and rilpivirine, with a half-life up to anything from 2 to 3 months, is been working very well if you give every 2 months, as shown by the latter two studies. And also it has also been supported by now many studies, Atlas and FIRE. When I browsed all these studies and the design of the studies, they all recruited patients who have got suppressed viral load. They have been well suppressed, then they're randomized into these different groups, and they did this. Again, if you are going to introduce in our region, we have got a very large number of people who are already on TLD, containing therapy in our regions, and we do not know many of them, whether they are viremic or not, because we are not going to do the viral load every 2 months or every 3 months. Annually is a viral load. So we do not know, can we use this just like that in our population to do this? So again, there's a very nice presentation came up in the last year CROI. Now it has been published now by Monica Gandhi and her colleagues from San Francisco. These are their own real-life clinic patients they recruited, where they recruited patients who had got both suppressed viral load and as well as people who didn't suppress. But one thing they did was, which might have some implication for our region, is they excluded patients who have got any NNRTA mutations. So because this rilpivirine, one of the drug in this 2-drug regimen, is an NNRTA, which can have an impact on that. So analysis with the primary endpoint with a viral load of more than 30 copies at the initiation of long-acting cabotegravir with rilpivirine over a period of 24 weeks. So this is a baseline characteristics. Again, I don't want you to waste your time fully on this, but I'd like to see these. They also recruited significant number of patients, almost like 43% of these in this study, they are being non-suppressed. They are being viremic. They recruited in this study for these 2-drug strategies. What they found in that, again, the study is, if you see these particular figures, all those who have got a suppressed viral load, who continue to be suppressed with this 2-drug regimen over the week 24s. But very interestingly and very surprisingly, what they found in that is 55 of the 57 people who've been viremic while giving this drug, 2-drug regimen, also had virological suppression. This data never existed. This is something very interesting, especially in our region. Even patients who are being viremic, if you just give this, there are many possibilities they'll get been suppressed. So they concluded that particular study stating that, particularly in people with HIV, without virological suppression at baseline, significant proportion of them have achieved virological suppression, which might change our practice, especially in patients who are not adhering to this drug. Again, the virological failure rate, what they've seen in this particular study in the pool population is almost similar like in other studies, what they've seen in clinical trial, in phase 3 trials. So they also suggested that this probably can be an effective regimen, especially in people who have got adherence challenges who are being viremic. So I thought this can be a take-home message for our patient population, but don't forget they excluded patients with NNRTA mutations. And again, last year at IAS, there is another very nice presentation came from Australia. I think some of the investigators might be here in the audience from Kirby. So what they did was they recruited in this particular study called JAPS on patients who have got suppressed viral load, almost around 60 people. But the investigators felt that these are the patients, they might be failing any moment because they had some sort of social issues. They have some social vulnerability issues, they have history of non-adherence, or they have housing issues, or so many other societal and many other psychological factors. They found that probably this population might fail. So what they did is they recruited this, but on the other hand, they have been virologically suppressed. They assessed very detailedly what are their various psychological issues which may impact, and following the needs, they also used variety of adherence measures using their regular GPs or with the formal support groups or with variety of type of groups. They used them, including their clinical staff, to improve their adherence to come back to the clinic for the injections. And in that, they found that while doing also, they were able to find almost good proportion of them. They were able to come back to the clinic for this 2 monthly injection shot. And they found in this trial, they are able to continue to suppress the viral load, and there is no significant adverse events to these injection site reactions to discontinue this. And the participants here had almost similar adherence and efficacy as those in phase 3 clinical trials. So I think these two studies, which has been presented last year and published last year, very clearly is there is a life for this long-acting injectable, even in a non-adhering population, even they are viremic, or even they are being suppressed. If they have issues, if you give some external supporters, it will work on that. So this is something can be a carry home. I think we should wait for little more time, next year, whether this will make it in our region widely, especially in the public health guideline. I know Malaysia has already been implemented, and there are other regions are doing this in resource limited setting. We need to wait for that. But on the other hand, there is a caveat. Now, we are living in a situation with NNRTA mutations. Significant number of our patients currently who are on TLD, they all been exposed to efavirenz or nevirapine in the past. Either you have been switched them after the treatment failure with NNRTA, or without knowing their viral load, you change them because of the public health guidance made you to choose. There could be a possibility of NNRTA mutation, which can impact on rilvipirin. At this time, we don't have any data on that. To solve this, there is a very nice study, not published yet, it's been evolving. Now, this was also been presented by team, I think, on the day one in the pediatric session. So what this investigator did is Rodney Ho and his colleague from University of Washington. He's one of the world-class pharmacist scientists. In fact, I know him personally well. We have collaborations with him in Chennai. So what he had done is he has put tenofovir, lamivudine, and dolutegravir in a single liquid, and had developed a nano preparation which is very stable. And they have studied this in non-human primate models, and this can also be given subcutaneously rather than an intramuscular injection, which might be very painful. So they have shown some proof of concept in the non-human primate models, which is going to now, I'd like to tell you the next phase is the clinical phase with the support from UNITAID and from WHO. Now we are moving into the clinical experiments. So I don't have any data on that. Still, we are in the PUC studies of preferred user characteristics, whether you want a subcutaneous or injectable or other preparations every 2 months or every 3 months. And hopefully, probably the next couple of years, we may come to you with this particular preparation. That is TLD, tenofovir, lamivudine, dolutegravir, as a long-acting injectable. So we may prefer this as a clinician working in this field for almost 3 decades. Now, when someone is on a stable therapy with the TLD, now, hey, if you're calling them, hey, I'm going to give you a different drug, which is an injectable. You don't want to take it every day, but every 2 months, but it's a different drug. They may scratch us, hey, I'm very fine, I'm stable. Why should I change all those? And also TLD also has got a lot of other good things about taking care of hepatitis B as well as in TB. You don't need to do anything. So to sort this, probably this could be, but right now we don't have the drug. Look for the data. But on the other hand, other long-actings are coming up. Use it based on the data what I showed now. So moving to these other long-acting injectables, we all know that lenacapavir, heavily studied here in Thailand too by Angeli and his group here in HIV-NAT. It's now been effective both in treatment naive as well as in experienced population, can be given every 6 months subcutaneously. I like to show that what can be impact probably this year is, in these particular trials, what they did is, for some issues with the preparation on storing this in the bottles, which US FDA found that there is some issue with that, not with the efficacy or not with the quality, but with the bottles what they stored. They asked to put the investigators on a clinical hold of this trial. So then the sponsors and the investigators, what they did is, instead of giving this subcutaneous, which couldn't be given because it was put on a hold, they also had a long-acting, same molecule of lenacapavir as a oral pill, which can be given every week. So they use this as a bridging till they get a US FDA approval and in this particular clinical trial. So what they found in that is, when they did this, by using this weekly oral lenacapavir, they found the same virological suppression. So this is something where we can look into that. Again, I heard that the company is also developing this, whether this can be a monthly, weekly pill, or even beyond. So that means the patients who don't want to take this injectable on a long-acting, there are some promise that we might have some long-acting, oral pill in the horizon. Moving to a different population, again in the top 5, I think I need to capture the time. So moving to the pregnancy, we all have given TLD. That's a gold standard. Every studies have shown that that's very safe in pregnancy now. Zero transmissions almost. So and TAF, bictegravir, all our previous guidelines said, oh, it cannot be given because of we don't have data or something can happen. And all those. So hence, this particular study was been developed now, been presented. I hope it's been published. What they did is investigators recruited 33 pregnant women on this particular regimen called TAF, emtricitabine, bictegravir, which is a so-called gold standard for treatment in North America. They have this as a single pill, TAF, FTC, and bictegravir. But they didn't have data on the pregnancy. This is one of the first data they presented. at the IAS conference, now been published. What they've shown in this particular graph is, this x-axis is, this is a PK study, and here y-axis is a plasma concentration of the bictegravir, and this x-axis is duration in terms of an hour. So what they've seen is you can have a different graphs, where the first two graphs are patients who are in the week 6 and 12 of postpartum, and the bottom two is, this is data on when they are on the drug levels at the second and third trimester. It very clearly shows that in the second and the third trimester, bictegravir level comes down very drastically. It's also been shown that the total and unbound bictegravir in the area under the curve is almost like 59 and 41 percentage lowers respectively during the third trimester at week 12, and also 41% lower as compared to the non-pregnant studies, especially in the third trimester. So it can have an impact, especially in terms of transmission as well as in terms of efficacy. What they found in that particular thing is 100% of the women, 33 women, they all have undeclared viral load at delivery. Even they have this drug levels went down. And also they studied about the cord blood concentrations and neonatal median bictegravir half-life, which is no major significant to show that it can harm them. And also there is, interestingly, no cases of perinatal HIV transmission, and this drug was well established. So that means there could be another drug, not necessarily TLD, where TAF, FTC, bictegravir can be an option. Wait for the data. I'm not sure that whether DHSS, they are about to be meeting, this week or something to make these as a guidelines, to discuss this data. We need to wait for it. I'll be ending up soon by showing that what about these BNAPs? So we have this lenacapavir now almost in a very advanced phase was a long-acting drug. And along with that, which can be given as every 6 months as a subcutaneous injections. Along with that, can we also find another, today we don't have a pairing drug along with that to give every 6 months. The other drugs are either every 2 months as a long-acting injectable or as an oral tablet, every day have to be done. So if you give something every 6 months, something everyday oral tablet, patients are going to be forgetting. Even as a care provider, you do not know what you are given in the past. To start these two BNAPs being developed called terapamab. So I'm going to use the word in future, TAP, not because I don't like this word, because I cannot be able to pronounce in every slide. There is another one called cilnarivimab, which is again a BNAP, and I'll call it as a SAB. As we all know, the lenacapavir can be given every 6 months subcutaneously. These broadly neutralizing antibodies, both TAB and SAB, modified to extend their half-life to give every 6 months dosings. And again, this TAB targets a CD4 binding site at GP120, and SAB targets a V3 glycan at the viral entry level. And again, these both were being combined along with the lenacapavir, to study whether they can have a virological suppression at around week 24 to 26 if we give every 6 months. This is the design of the study. I will not go into the details. Two different preparations were being compared. One is, these are the patients who are being virologically been suppressed, almost around, this is a small scale study, 21 patients, where lenacapavir along with the TAB and SAB, given at 30 and 10 milligrams each, and lenacapavir TAB and 30 and SAB 30, we've been used. The design of the study is up to week 26, and after that, restart on ART and continue follow. This was the original design of the study. And again, what they found in that particular trial is at week 26, they found almost in both arms, almost equal in terms of virological suppressions. But in the arm with 10 milligrams, they found 10 of them, failed, and but there is no virological data available on the 30. But if you see this, there are a significant number of people, they had a virological suppression on this. And also when they studied on people who had failed, there is one patient, that is 10%, where they did a phenotypic susceptibility, and they found that there is no lenacapavir resistance being seen, and they're all being suppressed on the baseline antiretroviral treatment. So again, there is no serious adverse events and to discontinue this study. And again, this proof of concept, we should be welcomed. Again, the investigators concluded stating that significant proportion of these patients had a suppressed viral load of giving these every 6 months of injections, the lenacapavir and these two broadly neutralizing antibodies, and they are being found safe. And now the phase 2 study has been ongoing. We hope probably in CRI there could be a presentation, or by mid of this year, we might wait for this. Again, this might impact our things because there are patients where they want every 6 months treatment. They come to us, hey, I'll have a shot, gone. It's like therapeutic vaccination. Just have this shot, go come back after 6 months. This is something what our patients will love in future. Again, we'll wait for more data on that. I'll conclude my talk by saying in some of those on complications in HIV. As we all know about this advanced study, which has been studied in sub-Saharan Africa and Joburg, where they have shown significant weight gain to integrase inhibitors, particularly in women when they have been paired dolutegravir with TAF-containing regimens. And because of that, the whole world has been talking about this integrase, what to do with this. So there are several studies that I picked up, 2 studies, which might impact our practice, and especially in your clinic tomorrow when you go back. Someone who has been virologically suppressed, and they have a more than 10% of weight gain when they are on integrase inhibitors. They randomized into 2 different regimens. One is they continued the same integrase inhibitor. Another one, they switched them because whether this switching can prevent the weight gain. They put them on boosted darunavir. It's a very nice study. Just for one at a time, I'm not going to the details, but I like to tell you that primary endpoint is changing in the body weight from baseline at week 24 analysis. And they found in this, there are some changes in the weight gain between the arms, but it was not being, significant in between the arms. Either you continue the same integrase or the boosted darunavir. Then you may ask a question, hey, darunavir is a protease inhibitors, which can cause increase in weight gain because of the ritonavir. Why you didn't try any other regimen? To sort that, very recently, this has been presented at the IAS meeting, this newer regimen, which is called doravirine, where again they randomized into this particular study. There are 2 different studies they pulled together, P17 and P18, and data together to show that whether this newer regimen with doravirine, which is a 3rd generation NNRTI, and a new drug under development called slatravir, which has been through a lot of hurdles, but now is moving forward, which is again not a protease inhibitor, not an integrase inhibitor, which is a translocation inhibitor, like an NRTI, it's called NTTRI, where they use this and they compared with continuing the integrase inhibitors. So again, the 2 different studies, being simultaneously being done, and the pool data very clearly showed that both in the mean weight change as well as changes in the peripheral and trunk fat, there is no difference in terms of continuing the integrase and putting with the newer regimen, which is non-PI, non-integrase. So that means in your practice, somebody's gained weight, sit tightly. Don't keep moving your best regimen out. Best regimen is here is integrase inhibitors. You have to do this because the trials have shown whatever you have changed is not going to help them. On the other hand, you can ask them to follow the lifestyle modifications, look for any of their NCDs, prevent them. How to prevent them? Again, we all know that these are the trials. Studies have shown sub-analysis, NAMSAL in West Africa, advance in sub-Saharan Africa, as well as our own studies, depth, have shown on integrase inhibitors on a long run, not only the weight gain, but also can cause hypertension, and as well as the cohort studies, the response cohort studies have shown it also can dyslipidemia and the new occurrence of diabetes over a period of time while they're on integrase inhibitors. Can we prevent any of these complications? To sort this, we have this famous REPRIEVE trial, which again you would have heard from the previous presentation, hence I'm not going into the detail. So what we did in this trial is, I like to tell you that the largest recruiter of this trial is here, Dr. Anjali. I think we should give her a big clap. HIV-NAT program recruited the very largest number. And of course, we are not able to beat. We wanted to beat HIV-NAT, but we finished 2nd or 3rd, in recruiting in this particular trial. It's a very large study of 7,000 odd patients globally. And this is a landmark trial where we use pitavastatin against a placebo on patients who never had cardiovascular disease of more than 40 years of age, with an endpoint of any major cardiovascular event. We call it as MACE. I will not go into the details of study, but I want to show the snapshot analysis showing that we found 35% reduction in the first primary MACE, that is any major adverse cardiovascular event as compared to placebo. And also we found that in terms of death, and we have found about 21% reduction by giving these statins in patients who are on HIV and on suppressed viral load. And following this, DSMB asked us to stop the study. And we were very sad because we have been part of this study. But on the other hand, it's great for our literature that we found that this particular drug, statin, will work. And following this, now all these studies have been published. And also like to tell you that European HIV guidelines have already changed their guidelines. Anyone who is HIV positive more than 40 years, they have started recommending. DHS guidelines seriously discussing. I think probably this or next week they are going to recommend, and this might be serious discussions in our WHO guidelines soon. So probably this is something what you can use it in our region, to prevent, cardiovascular complication, particularly in people with HIV who are suppressed and on long run who are at a high risk to develop cardiovascular abnormalities. I like to end by stating that, whatever we learn, especially in virologically suppressed patients, you have to make sure that they are not comorbid with other conditions, like one of those antiretroviral toxicities or pill fatigue or something. This is something what news is going to happen. You may have to reduce a drug, like 2 drugs, or you may have to use a new investigational drugs, or a lot of these long actings coming up. So wait for it. It's going to be a little messy for our clinicians, but great for our patient population, so that they'll continuously virologically suppress and won't be comorbid. Just by concluding, stating that today, whatever we do, HIV still persists. So it's a lifelong treatment. Sterilizing cure happened on 5 or 6 people by using stem cell therapy. I'm not going to the details, but this method is definitely not scalable. But on the other hand, approaches like BNAPs and antiretroviral treatment combinations are promising. Wait for it, especially every 6 months. I will love that. But what we have is what is called the functional cure, which we are all doing. Continue to do this and make sure that U is being maintained. And preventing non-communicable disease will be the future question in our patient population. With this, again, thank you for this opportunity and thank you for this patient hearing. Thank you so much.